This presentation is a short overview of an important clinical entity, the pharyngeal functional dysphagia. In this short overview, we'll quickly cover examples of 3 diagnostic tests and examples of management of 2 common disorders. The diagnostic tests used are the fiber-optic endoscopic examination of the swallowing, the FEES, the video fluoroscopy in use in aspiration, PASS, and the video fluoroscopy used in dysphagia, the Bolus residue scale. The examples of the management would be for aspiration and the management of Cricopharyngeus dysfunction. And these are the 12 steps of the standard FEES procedure, starting with checking the velopharyngeal competency when the scope is held above the level of the soft palate, followed by introduction of the scope a little bit further to check the hypopharynx at rest and notice if there is any secretions or saliva pooled in there, followed by pharyngeal squeeze and testing of the sensation of the pharynx and the larynx, and then checking of the laryngeal competency by again maneuvering the tip of the scope a little bit to see if there is adequate adduction and abduction and laryngeal elevation, testing the cough reflex, and then if there are reasons to suspect a high risk of aspiration, you start the introduction with ice chips rather than colored food and drink. If this can be tolerated, you go up the ladder to the colored food and drink, and then assessment of any aspiration or pooled retained secretions in the pharynx, followed by the examination of the upper esophageal sphincter area. And by the end, if you have identified the cause of the problem, you can start trying different therapeutic adjustment in terms of bolus volume, texture, consistency, rate of introduction, head positions, or efforts from the patient to swallow better. The location of any pharyngeal residue after the swallow would help in the diagnosis. If food is retained in the vallecula, like here for example, this may point to weakness of tongue-based contraction, weakness of pharyngeal contraction, or weakness of the hyolaryngeal elevation. Whereas if there is accumulation of the colored food or drink in the lower part of the pharynx, like in the piriform fossae, for example, like in here, this may point to a problem in the opening of the upper esophageal sphincter, like, for example, cricopharyngeal dysmotility, or weakness of the contraction of the pharyngeal muscles. Step number 10 is to notice any laryngeal penetration or any aspiration of the colored bolus into the airway. This could happen due to a variety of reasons, including incomplete glottic closure, impaired laryngeal sensation, reduced movement of the larynx, particularly elevation during swallowing due to any defects in the hyolaryngeal elevation, any abnormalities of the hyoid bone elevation during the swallowing. It can also happen if there is a reduced duration of laryngeal and glottic closure during swallowing in relation to a delayed swallow or a presence of pharyngeal residue or prolonged pharyngeal transit time. If there is enough residue in the hypopharynx when the glottis resumes opening, there is always the chance of a spillover into the airway. Video fluoroscopy remains the best available method of identification and quantification of disorders of the swallowing in pharyngeal dysphagia and or aspiration. The amount of information provided by video fluoroscopy is enormous and covers the flow of the radioopaque bolus. It's the timing, the patterns of failure or disorders during the swallowing act, any regurgitation up the nose or any spillover in the larynx. Because such amount of information is vast, It's usual that the video is run several times, some of them with a slow motion. It's also essential that we focus on one aspect of the swallowing act at a time and use validated scoring system to register any abnormalities in that act. When we are looking at any evidence of aspiration, we use the penetration aspiration scale, which is the gold standard of quantification of aspiration. If we are looking for problems in the flow of the bolus down the hypopharynx into the esophagus, we use things like the pharyngeal residue scoring system. In this presentation, we'll focus on the penetration aspiration scale, which scores the various degrees of aspiration. The penetration aspiration scale is an 8-point scoring system reflecting the severity of aspiration by the depth of the invasion of the aspirate material down the airway. Starting with 1, in which there is no aspiration, the material does not enter the airway, the examination is normal, and the most severe form of it, number 8, in which there is silent aspiration, the aspirate material goes all the way below the vocal folds into the trachea or even the bronchi, is not ejected, and there is no attempt at cough because there is failure of the sensory as well as the motor mechanisms to clear up the airway from aspiration. Between 1 and 8, it goes into different levels according to the depth of the invasion. In 2 and 3, the aspirate material remains in the supraglottis above the level of the vocal cords. In number 2, the material is ejected after it penetrates into the supraglottis. In number 3, it does not eject because there is a failure of the sensory element of the supraglottis, the superior laryngeal nerve. In 4 and 5, the aspirate material goes a bit deeper and contacts the vocal folds into the areas of directly above the vocal fold. Again, number 4, it's ejected from the airway during promptly, and in number 5, it is not. In 6 and in 7, the material goes below the vocal folds. In number 6, again, it's ejected from the airway by a good cough reflex. In number 7, it's the ejection is attempted, but the material is not completely cleared. So we know that there is a sensation in the subglottic and the tracheal area, some sensation, but the cough is not effective in clearing up the airway. In number 8, the material goes all the way down below the vocal folds into the trachea. It's not ejected, and there is no effort made to eject it because there is sensory as well as motor failure. And finally, to the last level, where there is silent aspiration in level 8. The aspirate material passes through the larynx, the vocal fold levels, into the trachea. It's not sensed in the trachea, and there is no attempt at coughing it, and it passes directly into the airway. You see the aspirate material going directly through the trachea into the airway with no attempts at coughing. Then we know that there is an impairment of both the sensory and the motor arcs of the cough reflex. In addition to the use of video fluoroscopy in the quantification of aspiration by the penetration aspiration scale, video fluoroscopy is employed in the assessment of dysphagia and quantifying it by the use of several scales, the simplest of which is the Bolus residue scale, which quantifies dysphagia by the presence or the absence of a retained pharyngeal bolus in 3 specific sites, either the vallecula, the piriform sinuses, or the posterior pharyngeal wall. In this scale, if there is no residue at all, then it is level 1. If there is only a residue in the vallecula, that's level 2. If there is a residue in either the piriform sinus or the posterior pharyngeal wall, that's number 3. If there is a residue in the vallecula and one of these two sides, that's number 4. If the residue is in the piriform sinus and the posterior pharyngeal wall, it's number 5. If the residue is in all 3 sides, that's number 6. There are more than a dozen different surgical procedures for the treatment of chronic aspiration. Which operation for which patient will depend very much on quantifying the severity of the aspiration. For mild symptoms, mild degrees of aspiration, a diet modification and perhaps some exercises would help these patients. It's rather common to have mild degree of aspiration, particularly in the elderly and in certain neurological conditions. Moderate aspiration would require some intervention in the form of swallowing rehabilitation, different exercises and different head and positions would also help, plus the dietary modifications. But it is the severe aspiration that requires tubal feeding or is life-threatening, that requires surgical intervention. And these surgical interventions can be straightforward, like in a peg feeding or a tracheostomy, or could be more complicated, like cricopharyngeal myotomy, injection and medialization of the vocal cord, arytenoid medialization and rotation, laryngeal suspension, cricoid resection, laryngoplasty, and laryngotracheal separation, and finally either partial or total laryngectomy. The management of the cricopharyngeal dysfunction can be either conservative management or interventional management. In almost all cases, with the exception of 3 groups of patients, we start with the conservative management, except in patients who have aspiration, in patients who have absolute dysphagia and cannot swallow their own saliva, or in patients who have signs of severe malnutrition. Conservative management would be through diet modification, voice and swallowing retraining, swallowing postures, and in few cases some trial of medications, while the interventional management would entail things like Botox injection, open or endoscopic Cricopharyngeus myotomies. Another common cause for aspiration is glottic incompetence, either due to vocal fold palsy or persistent glottic gaps following injuries or operations. In glottic incompetence, the aspiration would usually happen during the swallowing and can be seen during video fluoroscopy and video endoscopy. The treatment for glottic incompetence would start with a trial of voice therapy to enhance a better glottic control and closure, and perhaps laryngeal elevation as well during swallowing. If this fails, then vocal fold medialization procedures, either by injections in the vocal folds or by type 1 thyroplasty. If the gap is posterior and it is large enough, perhaps with unequal levels of the vocal folds, then arytenoid rotation procedures may be considered. Cricothyroid plication, which stretches the vocal fold and adducts the vocal folds further, would also be helpful. If there is a persistent gap despite all these attempts, then a reshaping or resculpting of the whole laryngeal structures by laryngoplasty may be considered, including cricoplasty, in which parts of the cricoid would be resected to narrow the airway and help in the control of aspiration. Cricopharyngeus myotomy can be added to any of these procedures to improve the aspiration control. When the conservative management fails to control the symptoms of the patients, it's time to consider interventional management, starting with Botox injection into the cricopharyngeus muscle itself. This will induce paralysis of the muscle, causing a medical myotomy. This is temporary, however. It lasts for somewhere around 6 months or so. If successful, it can be repeated several times. But more importantly, if successful, it would tell that this patient will benefit from a definitive surgical or endoscopic myotomy to control his symptoms. The dosage of the Botox varies between different authors. Some authors started with very low dosage, and some would advise 120 units. We now use more the higher dose, like 120 divided in 3 injections and 3 points along the muscle circumference. Cricopharyngeus myotomy can be the primary treatment for cricopharyngeus dysfunction, for example, or can be a secondary treatment together with other procedures in other conditions. As a primary treatment for cricopharyngeus dysfunction, the selection of the patient should also include verification by video fluoroscopy or video endoscopy of a cricopharyngeal disorder. But preservation of the pharyngeal contraction is essential, and a good hyoid and laryngeal mobility is also essential, since a myotomy in the presence of bad hyoid and laryngeal elevation or anterior rotation would not provide good results. And the sensory supply of the pharynx should also be confirmed to be present. As a part of other treatment, as secondary procedure, in cases, for example, of aspiration, mild to moderate aspiration can be helped by the myotomy. In pharyngeal pouches, this is an integral part of the management, plus the excision or the suspension of the pouch. And it can also be combined with medialization procedures in case of recurrent laryngeal nerve palsy, as also can be combined with thyroplasties, with hyoidoplasties, and in partial laryngectomies. Cricopharyngeus myotomy is one of the commonest operations for oropharyngeal dysphagia. It can be carried out endoscopically or by an external approach. If it is done endoscopically, sometimes it can be carried out with a flexible scope with some sedation, or more commonly, it can be carried out under general anesthesia with the use of a rigid scope like the Weirda scope. The blade of the anterior blade of the scope will be placed anterior to the cricopharyngeus bar, and the posterior blade will rest on the posterior pharyngeal wall, and a laser would be used to incise the cricopharyngeus bar down to the level of the buccopharyngeal fascia. That's the white color in here. It's important to get into this level so as to reduce the resting tone of the muscle by about 50%. The operation by dividing the muscle does not abolish the resting tone of the sphincter altogether, but it can be reduced by about 50% to help in the opening of the upper esophageal sphincter. The complication rates for the endoscopic approach is about 6%. It's mostly some bleeding or sometimes restenosis of the muscle, but serious complications could happen if there is a perforation of the buccopharyngeal fascia and mediastinitis may develop. If the operation is carried out by the external route, it's usually done on the left side of the neck, dissection between the larynx and the trachea on the one side and the carotid sheath on the other side, down to the level of the prevertebral fascia, identification of the recurrent laryngeal nerve, and then rotation of the larynx and the pharynx medially would expose the posterior wall of the pharynx, and the myotomy would extend not only through the cricopharyngeus muscle, but also through the lower part of the thyropharyngeus muscle and the upper part of the esophageal circular muscles. And this would ensure a better result for the cricopharyngeus myotomy. By this, we come to the end on this short overview of examples of pharyngeal functional dysphagia. Salam alaikum.